All right, guys, this is the patient assessment medical instructions. So this is how to go through the patient assessment medical station kind of step by step. I'm going to have a basic patient scenario. On the day of, you will definitely be given more of a scenario. And I'll do another video where I'll actually demonstrate going through the station and what a passing test would look like. So we're just going to say for this scenario that we've got Joe here, and he is an 85-year-old male who's complaining of shortness of breath. So first and foremost, before you even start looking at your mannequin, you need to start with assessment of the scene and ensuring your personal safety. Every single year, we have somebody walk into one of the stations, normally not this one, but some of the other stations, and forget to put their hands up and say, BSI, is my scene safe? That is a critical fail criteria. If you don't do that as you walk into whatever scenario, whatever station you're doing, you fail right there. We'll still have to let you run through the rest of the scenario, but ultimately, you've already failed within the first 30 seconds. So first and foremost, BSI, is my scene safe? You should receive a confirmation that yes, your scene is safe. And then you say, looking at the scene, is this my only patient? And you should get a confirmation, yes, this is your only patient. Nature of illness, because this is medical, dispatch gave me shortness of breath. Even on our medical patients, we need to consider C-spine immobilization. I would say with this patient, he's laying in the bed, chances of him having some sort of head, neck, or back trauma, pretty slim to none. So I'll say I don't need to consider C-spine at this time. And then additional resources. Depending on how comfortable you feel, you may or may not need additional ALS resources. What you can say right off the bat is, I'm going to go ahead and call them just to be safe because I can always cancel them, which is completely appropriate. Or you might say, I'm not quite sure what's going to go on. I'm going to hold off on calling them, but I'll keep that in the back of my head just in case. So then we're still not even touching the patient. We're looking at our patient, and we're going to start our primary survey. That's going to start out with just a general impression. So your question to your proctor is going to be, so what do I see when I walk in? Is the patient showing any signs of distress? Can I see any visual signs on the patient? How are they positioned? And you'll get fed that information. So I would say, if I were walking in on this patient, I would say, I have for the sake of the scenario, elderly male laying in bed, doesn't appear to be propped up all that much, not really responsive to me as I walk in. So now that I have established that, I'm going to establish the chief complaint, as well as assess his level of consciousness using that ASPE scale. So the easiest way to do this, let's just talk to the patient. So, hi sir, my name's Alicia, I'm with the ambulance. What seems to be going on today? Now, if this was a true scenario, that proctor would interact with me if the patient was meant to interact. So if this patient were to respond to me, then that would mean the patient is either alert or verbal, depending on if they're tracking me as I walk in the room, or if the patient speaks to me based on my verbalization to them. If the patient doesn't speak to me on verbalization, then we're going to have to do a pain response. The easiest way to do this is to take your knuckles and rub along the sternum. That is very painful. If your patient is alert to painful stimuli, they'll go and kind of try and pull away from you, or they'll grab your hand and move it away. A couple of other things you can do. You can take right at the base of the nail and pinch really hard right there. That tends to work. A trapezius squeeze here is also a good way to check to see if your patient is responsive to painful stimuli. If not, then they're unresponsive. If your patient is talking to you in any way, then you could say, because my patient is talking to me, I know that the airway is open, and depending on where we're at, we may not need an airway adjunct. If your patient is semi-conscious, but you're still kind of worried about that tongue falling back into the pharynx, you can always take an NPA and secure that in the nose if the patient tolerates it. So now we've already moved on to the primary assessment, those ABCs. So we've got airway. If the patient's not conscious, I can always go ahead and open the airway. either using the head tilt chin lift or the jaw thrust method, depending on if I suspect trauma or not. So we'll go ahead and open the airway. One of the other things if your patient is unconscious that you may want to do is actually open the mouth and visually inspect to make sure that there's no teeth, no vomitus, no secretions that need to be suctioned out, or no potential for the patient's airway to be compromised. Once we've done and secured that, then we'll go on to breathing. You want to note a couple of different things about breathing, not just is the patient breathing. So the first thing we want to know is the patient breathing fast, slow, or normal? Is the chest rise symmetrical? And then what is the rhythm? Is it normal? Is it abnormal? Is our patient gasping? And then overall tidal volume. Does it look like they're breathing normally, or are they breathing abnormally deep or abnormally shallow? Once we gain that information, if we note that there's something off with the patient's breathing, then we want to fix that. Whenever we find anything wrong with A, B, or C, we try to fix what we can immediately. So if this patient, saying that he had shortness of breath, was not breathing adequately, or just for patient comfort, we can go ahead and apply O2. A lot of times your patients within these scenarios are going to be more on the critical side. It may not be feasible for you to put on a nasal cannula. Typically, going ahead and putting on a non-rebreather, starting at 10 liters per minute, is going to be what's sufficient for you. Next, we move on to circulation. So first and foremost, we're going to check for a radial pulse, which may or may not be there. If it's there, you want to note a couple of things about it. Same as with the breathing. Is it fast? Is it slow? Is it normal? How does it feel to you? Is it strong? Is it normal? Is it bounding? Is it abnormally weak? Is it regular in its rhythm? Or are you feeling extra beats? Once we check for the pulse, if it's not here in the wrist, but our patient's talking to us, obviously we know they're alive. So we're going to check essential. Even if we don't have a radial and we're not quite sure what's going on with the patient, if they don't have a radial pulse, we'll check essential pulse, looking for those same parameters. The other thing that we want to assess with circulation is the patient's skin color, temperature, and texture. The earliest indicator of shock that we're actually going to catch is that skin color, temperature, texture. The body, in order to protect itself when blood pressure starts going abnormally low, is to pull blood in towards the core where all of your vital organs are. And so it pulls it away from that skin. So skin turns pale, it gets cool, and it gets clammy or slightly sweaty. So we can check that as we're checking the pulse. We just want to take a look. So pale, cool, clammy skin indicates shock. The other thing is major bleeding. Now, if it's minor cuts, scrapes, etc., nothing that's going to cause the patient to, fun word, exsanguinate, which means to bleed out, we're not going to take care of it. We want to know about major bleeding. So a quick scan of our patient to see if we have any major bleeding. If we do, go ahead and control it. Typically, the type of bleeding that we're worried about is going to be enough that we're going to apply direct pressure and or place a tourniquet, depending on where that bleeding is. So my patient is pale, cool, and clammy. No major bleeding. We do have a weak radial pulse that seems rapid, but at a regular rhythm. So we want to treat for that. In order to treat for shock at the EMT level, we're going to apply oxygen, which we've already done, and we'll cover up our patient with a blanket to go ahead and keep them warm. Once we've gone through that ABC, then we're going to make our transport decision. Anytime that there's a problem with A, B, or C, that means critical transport. So you can either load and go, or you can stay and play. With this patient, because we found several different problems with A, B, and C, we're going to go ahead and make this a priority transport and load and go. The next step is that history taking. So there's two mnemonics that we use within the history taking. We use OPQRST and we use sample. We typically start with OPQRST first, and it works really well with pain complaints, but you can do a modified OPQRST. Our patient is having shortness of breath, so we'll ask our questions pertaining to that. So onset. So sir, when did this start happening? Gives an answer for that. P is provocation or palliation. So sir, does anything make this better? No. Okay. Does anything make it worse? Q is your quality. You're asking for an actual description of what's going on. So can you describe how you're feeling right now to me? Is it a tightness in your chest? Is it a burning? Does it just feel like you can't get enough air in? He'll give you an answer. If we're talking about pain, can you describe the pain to me? Is it sharp? Is it dull? Achy? Just try and get kind of a general description. Different types of ailments cause different feelings in pain. So that kind of helps us narrow down what's going on with our patient. R, does it go anywhere? Radiation. So, sir, are you having any pain? You are. You're having pain in your chest. Okay, can you describe that to me?